The next speaker, Dr. Deepika Gupta. She's Associate Consultant and Hemato-Oncologist at SMVD Narayana Hospital, Katra, Jammu. She specializes in benign and malignant hematology and bone marrow transplant and special interest in multiple myeloma and plasma cell dyscrasias. She has various publications, which includes publications on myeloma and plasma cell leukemias. She has presented national and international papers and has publications on international and national journals. She had achieved many awards, which include ASH Visited Award organized by Rajiv Gandhi Cancer, and she stood second in hematology quiz. She is also the DRNB Clinical Hematology Gold Medalist from our esteemed institute. So Dr. Deepika will take us through the clinical part, through the treatment and diagnosis, clinical diagnosis of multiple myeloma. Over to Dr. Deepika Gupta, who will tell us how to manage multiple myeloma.
Good evening, everyone. Thank you, ma'am, for your kind introduction, and also thank you for inviting me here. And also, I would like to thank the CHO for giving me this opportunity to be here. So I think Akshita will take up my slides, and I'll be just presenting it from here. My presentation is on the treatment of multiple myeloma. So, slide, yes. So, these are the various, I have just divided my presentation into introduction, the treatment of newly diagnosed multiple myeloma, that is transplant eligible or in patients with transplant ineligibility. What is new in myeloma, relapse refractory myeloma, and the upcoming therapies. So, briefly giving you the introduction, the multiple myeloma is characterized by the neoplastic proliferation of single clone of plasma cells producing monoclonal antibodies, resulting in the organ damage. So 65% of the times it is IgG, 20% of the times it is IgA, 16% it is only light chain disease. IgD is sometimes in 2% of the patients we see. Biclonal also we see in our routine practice, 2% of the patients, and IgM 0.5% of the patients. Briefly the clinical presentation. Next slide. So myeloma, briefly I'll be discussing, is already being discussed in the previous sessions. So there is production of abnormal plasma cells in the bone marrow, which actually produce a abnormal type of M protein, which primarily cause kidney damage and the fractures. That is, it causes the damage to the bones. Next slide. So hematologically, if we see the patients, most of the times they present to us with normocytic normochromic anemia, and sometimes with thrombocytopenia and leukopenia, although that is actually a less common presentation. And anemia is the most common presentation. And if we see the renal manifestation of myeloma, so it can present as a light chain deposition disease. It can present as AL amyloidosis. And the most common is that hypercalcemia is actually occurring, which is because of the increased osteoclast activation in the bones, so which is releasing a lot of calcium, and the calcium is actually causing the damage to the kidneys. So that is the most common cause of the renal damage in patients with multiple myeloma. And the patients, they are presenting sometimes with very high calcium and altered sensorium. Sometimes in the coma, they are presenting to us, and on evaluation, we get to know that the calcium is very high and patient is anemic and some other manifestations. So which gives us a clue that the patient can have multiple myeloma. Then the skeletal presentations is actually the very common presentation. Is patients mostly come to my OPD, especially in the smaller cities like Jammu where I'm practicing. I'm just seeing that the patients are actually not aware and there is a late diagnosis. So patients are mostly, the myeloma patients are coming on wheelchair to my OPD. So there is a lot of bony pains in these patients, and most of these have a lot of vertebral fractures. So a generalized body pain, that is because of the osteoclast activation in the patients with multiple myeloma, and other signs like the nerve damage, which is primarily because of the M protein, which is causing the damage to the nerves. Hyperviscosity, sometimes a presentation in myeloma, but if it is present, then we should rule out avoidance from macroglobulinemia simultaneously, and then a light chain amyloidosis, and which can present as heart failure in large level. They should also be considered when the patient presents to us with such manifestations. Next slide. So if we see the epidemiology, the multiple myeloma, it accounts for 1% of all the cancers and 10% of all the hematological manifestations. It is more common in African Americans or Blacks and less in Asians. So median age is 66 years and only 10% of the patients are younger than 50 and 2% are younger than 40 years of age. If you see the male-female ratio, it is 1.4 is to 1. And although a data from India is not available, but it is less common than West, but it is more in the younger patients. Next slide. Yes, if we see the natural history of multiple myeloma, the disease is actually incurable. So, from the inactive stages, already discussed like MGUS, smoldering myeloma, and now there is an entity that is high risk smoldering myeloma to the active myeloma when we actually treating the patients. So, in active myeloma, what is the course? So normally, the course is like that: the patient receives the treatment, patient goes in remission, then patient again relapses, then takes the treatment, then remission occurs, then again relapses, then remission occurs, and until it becomes a refractory and a progressive disease. Next slide. So the survival. So now there are so many therapies, like from the anthracyclines and various other chemotherapies in the era. Now we have come to an era in which we have the newer agents, newer options like the CAR T cell therapies and various other bispecifics. The overall survival of the myeloma is actually increasing over the years. Next slide. So if we see the coming to the treatment of the multiple myeloma, so a newly diagnosed case of multiple myeloma. Just a minute. Sorry, I'm actually from the mobile. So I'm getting some calls in between from hospital. So a patient of newly diagnosed multiple myeloma comes, as already discussed by the Ritu ma'am. We have to risk stratify this patient, and then we have to decide that what therapy the patient is eligible for. That I'll be discussing later on. So first, apart from risk stratification, we have to see whether this patient is eligible for transplant or patient is not eligible for transplant. So we have various scores like Charlson Comorbidity Index. And apart from that, the most important is actually the performance status of the patient, whether the patient has any comorbidities, what is the age cutoff. Age cutoff is actually taken as 60 years, but we have to consider various other factors like what is the physical status of the patient, what is the performance status of, what is the biological age of the any comorbidities. So all of these are considered while making eligible patient, whether the patient is eligible for transplant or not. So if the patient is eligible for transplant, we have to do induction. Then we have to do an early transplant, or if the patient is not willing for transplant, maybe because of any reason, we can actually collect those stem cells and we can cryopreserve them and then put the patient on maintenance until the patient relapses or there is a progression of disease. And if the patient is not eligible for transplant, then induction followed by maintenance. Next slide. Am I audible clearly? Hello?
Yes, ma'am.
Okay. So if we see the various treatment options in the multiple myeloma, I'm so sorry. So if we see the various treatment options in multiple myeloma, so proteasome inhibitors, next slide, go to the next slide. So proteasome inhibitors, which include the bortezomib, which is the most common drug, then carfilzomib and ixazomib. Then the immune modulators like thalidomide, lenalidomide, pomalidomide. The chemotherapies, which we are mostly not using in the current era in very refractory patients, we can use those in those patients. We can use like melphalan, bendamustine, and some combination therapies. Steroid is the backbone of multiple myeloma, dexamethasone in most of the patients, and some patients who are intolerant and elderly, frail patients, we can use prednisolone also. Then then the other evolved, most important evolving treatments are the monoclonal antibodies, that is daratumab and elotuzumab. And then there are some novel drugs also like selinexor and venetoclax. Even venetoclax is actually it is actually seen in various trials like Bellini trial in the patients of multiple myeloma, in which translocation 11-14 is there. So it has seen good results. And then the latest treatment, these are the CAR T cell therapies, which I'll be discussing. Next slide. So starting with the treatment of newly diagnosed multiple myeloma. Next slide. So next slide. Next slide. Yes. So we have so many options, as I told you, that we have so many options. So how do we sequence and how do we strategize these therapies to ensure the best outcome for our patients? That what should be the first line, what should be the second line, what should be the third line, and then beyond. Next slide. So this is the paper which actually said that it's very important to so that the policy is actually to hit hard at first. So the most effective therapies which we have should be chosen at the very start. We should not reserve these therapies at the time of relapse. If the patient is affordable, we should utilize all the therapies which are very good and should be started at the very start. So why? Because as the relapse occurs, these patients actually evolve, and the evolvement is in the form of the clones. So the patients, they become the clones become resistant, so they acquire various mutations. So what happens that when they acquire various mutations, they are becoming resistant to the therapies. So it's very important to start to actually choose the therapies which are available to us at the very start. Next slide. So the goals of therapy in the setting of a newly diagnosed myeloma is to achieve deepest and most durable response. So as the myeloma I told you incurable, so the deepest and durable response achievement is the most important thing. So more aggressive therapies upfront and consider risk status and transplant eligibility. And second is to optimize the quality of life. So to balance the efficacy with tolerability, to provide supportive care and shared decision making. Next slide. Next slide. So briefly, I'll be telling you about some of the drugs which we are commonly using in multiple myeloma. The first is the proteasome inhibitors. So how they are actually working, that is bortezomib, carfilzomib. Most of the times we are using these two injectable drugs. Ixazomib is costly, not easily available in our country, and it is an oral drug. So what is happening that so we all know that there is a ubiquitin and proteasome pathway for the degradation of the proteins. So what is happening that the various proteins which are actually causes the tumor suppression, so these proteins are actually degraded. They are getting degraded. So the apoptosis of the tumor cell is not happening. So these drugs, they actually inhibit the proteasomes so that those tumor suppressor genes they don't get degrade, and they are available for the destruction of the tumor cells. So one of the pathways how the proteasomes are acting, and another one, it is causing, actually it inhibits the angiogenesis by inhibiting the VEGF, that is the endothelial growth factor. So this is another mechanism. So this is a very complex diagram. So very shortly I have told you that how these are actually acting. So next slide. So coming to the second drugs is the immune modulators, so thalidomide, lenalidomide, pomalidomide. So thalidomide, most of the times we don't use this drug except when the patient has renal failure and we can't use lenalidomide. Then we mostly use thalidomide in our practice. Pomalidomide also in reduced doses, especially in the patients who are in dialysis. We can use pomalidomide also in renal failure. So how immune modulator? So by its name only, we can just get to know that it is actually modifying our own immune. It is modifying our immune system to fight the cancer cells. So it is actually causing the activation of the T cells and NK cells so that they target and they destroy the cancer cells. Secondly, it directly inhibits the tumor growth. It also helps in anti-angiogenesis. And next slide. So this is the main mechanism by which the immune modulators are acting. Then monoclonal antibodies, the most current and the current therapy is actually the daratumab, which is available, and we are using it for many years now, mostly in our first line of therapy only. So how daratumab, it is a target drug. So how it is acting, it is an anti-CD38. So we know that CD38 is present on the myeloma cells, on the plasma cells. So it is causing the blockage of that CD38 and causes the direct apoptosis. And second is by complement activation, it is causing the destruction. and by the antibody-dependent cytotoxicity, it is causing the destruction of the plasma cells. Next slide. So the treatment, the patients who are, this is the latest M-SMART guidelines, the patients who are eligible for transplant. So we risk stratify these patients, standard risk and high risk. So in standard risk, we have 11, 14, 6, 14 and other trisomies, hyperdiploides. So they all come in the standard risk. So if the patient is having standard risk, the treatment options which are daratumab, bortezomib, lenalidomide, and dexamethasone. So isatuximab is not available, so I will not discuss that. So daratumab, bortezomib, lenalidomide, and dexamethasone, 4 cycles we give. We collect the stem cells, the patients who are willing for the transplant. So we do the autologous stem cell transplant and then put the patients on lenalidomide maintenance. And those patients who are not willing for transplant because of any reasons, so we give more 4 cycles of daratumab, bortezomib, lenalidomide, and dexamethasone, and then put these patients on lenalidomide until progression. So most of the, this is the standard regimen, daratumab. Most of the patients in our country, daratumab, the cost is actually a problem. So if the patients are not affordable, they don't have any panels or any other insurances. So in those patients, we can just start with bortezomib, lenalidomide, and dexamethasone. So then in high risk myeloma. So high risk myeloma is either deletion 17p, gain of 1q, deletion 1p, translocation 4, 14, 14, 16, and 14, 20, or there is a double hit or triple hit myeloma. Then straight away the treatment is 4 cycles of daratumab, len, and dexa. Then autologous stem cell transplant, and the maintenance we have to put 2 drugs. The bortezomib plus lenalidomide both should be added in the maintenance of the patients who had high risk myeloma. Next slide. So the goal of therapy in newly diagnosed transplant eligible myeloma is the induction therapy to achieve very good partial response or better, maintenance therapy to maintain and improve the progression-free survival, autologous stem cell transplant to achieve the MRD negativity, which we'll be discussing later, and to deepen the response and to improve and maintain the quality of life. Next slide. So in patients who are not eligible for transplant, so if the patient is standard risk and not eligible for transplant, then the latest guidelines say DARA, BOTI, LEN, and DEXA, 9 cycles, followed by LEN maintenance. And the patients who are frail patients, there are some scores for the frailty in multiple myeloma. They're available online. So for the frail patients, it is DARA, lenalidomide, and dexa. Bortezomib, most of the patients don't tolerate frail patients because of the peripheral neuropathy they develop because of the bortezomib. And for high risk, it is again 9 cycles of the same, followed by borti plus len maintenance. And for frail patients, it is 9 cycles emitting the. So we have to just take out the borti and the 9 cycles of borti, dara, len, and dexa, followed by a doublet, that is dara plus len, or maybe a borti and lenalidomide maintenance if the patient tolerates. Next slide. So what are the newer treatment approaches? First is MRD. Second, the carfil-based induction is another treatment option. Like bortezomib-based induction we are doing commonly, but there are trials which support the carfil-based induction also, and then daratumab-based induction, which we have already discussed. So next slide. So MRD, very shortly, I'll just tell about this because I think then Jyoti ma'am will be telling about this. So MRD, it refers to the small number of myeloma cells that may survive in the body after treatment. So for patients with multiple myeloma achieving undetectable MRD, it has been proposed as a surrogate marker for the progression-free survival and overall survival. So these cells are so small that they can't be detected by the routine tests as seen by the microscope. So IMWG has incorporated MRD negativity into its response criteria, so emphasizing its importance in assessing the treatment response and prognosis. So in meta-analysis that combined the data from more than 2,500 patients, it enrolled on 4 phase trials, and patients who achieved complete response or better with undetectable MRD, that they had a better PFS when compared to the patients who were actually MRD positive but had complete response but MRD positive. So MRD is now the latest, which is holding a very important role in the patients of multiple myeloma. And it next slide, and it has already been validated in various trials in multiple myeloma on various drugs. Next slide. So in this trial, this is a sum up of the various trials, and it showed that the patient who achieved daratumab, and they had more than complete response, and they were MRD negative. They had a better PFS as compared to the patient who had received dara, had achieved more than complete response by the standard IMWG criteria, but they are MRD positive. So the patients who were MRD negative, they had a better progress. They had a longer PFS as compared to the patient who are MRD positive. So this is the data from the various trials. Next slide. So while patients with undetectable MRD do better than those with detectable MRD, it is not known whether altering the therapy based on MRD status will improve the outcome or not. Next slide. So another landmark trial, which actually led to the approval of the daratumab in patients of multiple myeloma as the induction regimen, was the Griffin trial. So very shortly, I will be telling you about that patients who were transplant eligible, 18 to 70 years of age. They were basically taken for the trial, and they were randomized into the two groups. One is daratumab, lenalidomide, bortezomib, and dexa as induction, and the second group in which DARA is not given and the patient received lenalidomide. R is Revlimid, which is actually lenalidomide. V is Velcade, which is bortezomib, and D is dexamethasone. So both of these groups actually, after induction for 4 cycles, they underwent autologous stem cell transplant. Then both of these groups received the consolidation 2 cycles, and then they were put on the maintenance. So first group was DARA maintenance, and second group was only the lenalidomide maintenance. So next slide. So it was seen that the patients who received the daratumab, they achieved stringent complete response, and even more than complete response, and throughout various years, and even MRD negativity was actually maintained throughout the years, and the MRD negativity also favored the DARA group as compared to the patients who did not receive the DARA. Next slide. So the DARA maintenance also continued to improve the MRD negativity in this data. And after 2 years of daratumab maintenance, the 29% of the patients who achieved DARA became negative after they were MRD. Previously, they were MRD positive, and 29% of these patients, after achieving DARA maintenance, they became MRD negative. Next slide. Another trial, that is the fourth trial, in which carfilzomib was actually studied as a induction regimen. So in this trial, what they have taken newly diagnosed multiple myeloma, they were transplant eligible. They randomized into 3 groups. So in the induction, it is first group which received carfilzomib, lenalidomide, and dexamethasone 4 cycles. In the second group, it is carfilzomib, then cyclophosphamide and dexamethasone. And in the third group, it is carfilzomib, lenalidomide, and dexamethasone. So the first 2 groups underwent transplant, and third group achieved 4 more cycles of the same regimen. Then after that consolidation, they received 4 cycles again. So third group in total received 12 cycles. And then they were put on the maintenance. The first group was given only lenalidomide, and second group received carfil plus lenalidomide as a maintenance. Next slide. So it was basically seen throughout the standard risk, high risk, and double hit group that the patients who achieved carfilzomib in the induction plus they first group, that is carfil as induction plus autologous stem cell transplant, when it was compared to the second group in which the cyclophosphamide was added along with the carfilzomib, so the better outcome was in the first group, and it was significantly the curves are actually separating. The blue one is the first group, The yellow is the second group, and the third group, that is who actually received 12 cycles, is the third group. So clearly actually telling us that the Carfil as a part of induction instead of the bortezomib is doing good, and is progression free survival is actually improving with that. Next slide. So coming to the third part of the treatment, that is a second part actually, if the that is after induction, the autologous stem cell transplant. So before the availability of novel agents, the high dose chemotherapy, that is melphalan 200 mg per meter square, followed by autologous stem cell transplant, has been the standard of care. So it resulted in improved response rate and depth of response after standard induction, translating into the prolonged survival. So it has a mortality of 3 to 5%, and lately its role has been questioned, giving the advancement in the induction therapy. So there are so many regimens, so the role of autologous transplant is being questioned. But next slide, there are various trials. So shortly about to the PG students, that how we are doing the autologous stem cell transplant. So after the induction regimen, what we are doing, that if the patient is eligible for transplant, so it is an autologous transplant. So we don't need actually the donor for that. So we do a bone marrow assessment before the transplant to actually see that whether the patient has achieved what type of response. And then if the patient is eligible for transplant, so what we do, we give 5 days of some the stem cell mobilizing agents. So we are mostly giving the GCSF and the Plerexafor in our regimen. And then when after 5 days, we see what is the CD34, that is stem cell count, and then we harvest these stem cells from the peripheral blood. So nowadays it is peripheral blood stem cell transplant only. So we just harvest these cells, and then these cells are stored in the blood bank, and then we give the conditioning regimen to the patient to actually eradicate all the myeloma cells. And it is melphalan which is given in the multiple myeloma, and 200 mg per meter square is the dose. It is modified if it is if renal disease is there. And then those stem cells, after melphalan, after 24 hours of completion of melphalan, we reinfuse those stem cells which were preserved in the blood bank, and then we wait for the recovery, that is the engraftment. So in autologous bone marrow transplants, most of the times the engraftment is by day 10. So next slide. So this is in short that how we are doing the autologous. So the various, we are talking that there are so many regimens, so many good drugs which are now available. So whether the autologous is actually holding any position or not. So there are various trials which were done, and it basically showed that autologous stem cell transplant has a very important role, still holding a very important role. Next slide. And when in this study, it was compared that the patients who received botulinum dexa, who underwent transplant, and who did not underwent transplant. So patient who underwent transplant, the PFS was more in patients who underwent the transplant than the patients who did not undergo. So autologous stem cell transplant still holds a very important role in patients after induction regimen. So next slide. So this is another trial which actually supports the autologous stem cell transplant. Next slide. So next slide. So coming to the third part of the therapy, that is the maintenance therapy. So maintenance therapy, so since myeloma is an incurable disease, so we have to give something to actually prevent some relapse. So maintenance therapy is the use of the ongoing low intensity chemotherapy to eliminate or to suppress the minimal residual tumor clones. So maintenance therapy is administered when disease is in remission, either undetectable or at the lower level. So the lenalidomide was compared to the placebo in various trials, and it was shown that the PFS was better in the patients who had received lenalidomide as the maintenance therapy. Next slide. And same as I told you that in higher risk groups, next slide, in higher risk groups, the maintenance therapy is with the double agents, that is the boti plus lenalidomide. Next slide. So next slide, Akshita. We can just cut it short. So this is the standard IMWG criteria. That is the stringent complete response, very good partial response, stable disease, and then progressive disease. Next slide. Next slide. So coming to the very shortly about the relapse refractory multiple myeloma. So almost all patients with multiple myeloma who survive the initial treatment will eventually relapse and will require further therapy. So relapse or refractory multiple myeloma is usually identified on routine surveillance, which is performed during the treatment or after the completion of the treatment. And choice of the therapy is determined by the various factors and disease characteristics such as quality and duration of response and aggressiveness of the disease. Next slide. So there are various factors which basically help which basically guide us that what should be the next line of therapy. And these factors are patient related factors like age, what is now the performance status, renal insufficiency, poor bone marrow reserves, then the what is the cardiac status, then disease related factors, that what initial therapy patient had received, what was the response to the therapy, how much the time the patient was in remission, what was the cytogenetic abnormalities, and whether what is the aggressiveness of the disease now, whether the patient is now developing secondary plasma cell leukemia or not, and then again the ISS staging. Then another treatment related factors like the what was the response to the first line therapy, and then other factors. Next slide. Next slide. So coming to the last part of the treatment, we can just skip few of the slides. Next slide. Next. So we have to, now we know that we have so many treatment options. So we can choose that what second line and what third line treatments can be. So I'll not go into the details. I'll just discuss about the last part of my presentation. Next slide. So this is the latest, that is the I was talking about, was the CAR T cell therapy. So this is an antigen which is against which the CAR T cells are being targeted. So this BCMA, it is on the myeloma cells, that is on the plasma cells, and it is the current target for the CAR T cells, which are now which are in various trials, in which various phases of the trials. Next slide. So the CAR-T is the latest form of the treatment. Again, I'll not go into the details. So I'll just summarize my presentation. Next slide. These are the various CAR-T, gene. Next slide. We just skip Akshita few slides. Go to the conclusion part. Next. Yes, next. Yes. So the strategies of frontline therapy continue to evolve. DARA, LEN, and DEXA, and the LEN, WATI, and DEXA remains the preferred options in transplant ineligible patient. Quadruple therapy offers deep, durable responses, and further study is needed to answer the questions regarding the treatment duration and utility of MRD in guiding the treatment. Thank you. Next slide. Yes, thank you. So that is all from my side.
Thank you, Dr. Deepika, for a very lucid explanation of how the multiple myeloma patients are managed and treated nowadays, and how the therapy has evolved over the time, and the latest drugs, carfilzomib and daratumumab, which, as you explained, the initial induction, they have come to the initial induction phase. Also, autologous stem cell transplant, where and when we should do.